Good afternoon, our dear students. I'm glad to see you on our lecture, and today I have a lecture after a period of stopping due to war of Ukraine. After Russian aggression against Ukraine, you had a more than month period of stopping of your education, and from 28th of March, we renovate our study, and I hope everyone will learn all material carefully and continue your education. Today I have a lecture from third course for MM groups, and topic of our today's lecture are named acute coronary syndrome. Usually, I read this topic. It is a complex of two lectures about coronary insufficiency, and it consists of two parts. Usually, it is acute and chronic coronary insufficiency. Chronic forms, it was first lecture. Unfortunately, it was during the period of stopping of your education, but you can find this lecture on my YouTube channel from the previous year. It's named Syndrome of Chronic Coronary Insufficiency, and you can find it in recording. And today it is another part of this lecture. It is acute coronary insufficiency, or another and more useful name for this syndrome, it's acute coronary syndrome. Okay, let's discuss what is acute coronary syndrome. First of all, plan of our today's lecture. We're going to give definition. We will discuss epidemiology. We will discuss risk factors, etiology, mechanisms, classification, clinical investigation, and diagnosis of acute coronary syndrome. Let's give definition. Acute coronary syndrome has evolved as a useful operational term that refers to a spectrum of conditions. That's why it's not a disease, it is a syndrome that include several conditions compatible with acute myocardial ischemia and or myocardial infarction, that are usually due to an abrupt reduction in coronary blood flow, ranging clinically from those for ST segment elevation myocardial infarction, or a short abbreviation, it is STEMI. Two presentations found in non-ST segment elevation myocardial infarction, abbreviation and STEMI. These two abbreviations, STEMI and NSTEMI, are very, very useful, and you will see it in all literature that you will use for studying. And another condition in acute coronary syndrome, it is unstable angina. That's why it is three main conditions: unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. Most patients with STEMI develop Q-positive myocardial infarction or myocardial infarction with pathological Q wave, and a few develop a non-Q myocardial infarction. Most of those without ST elevation develop a non-Q myocardial infarction, and only few may develop Q-positive myocardial infarction. That's why it is a relation. It more old terms Q and non-Q myocardial infarction, and now it is more modern and more specific, more correct term. It is ST elevation and non-ST elevation myocardial infarction. It is more specific terms, but they are related to each other, and in most cases where is ST elevation, in this case Q, pathological Q. Where is no ST elevation, usually it is no pathological Q. The acute coronary syndrome associated with high healthcare costs, frequent recurrences and hospitalizations, and high risks of sudden death and short-term mortality. Let's discuss especially about each form. Unstable angina. Unstable angina is defined as myocardial ischemia at rest or minimal exertion in the absence of cardiomyocyte necrosis. Among patients presenting with suspected non-ST elevation acute coronary syndrome, the introduction of high-sensitivity cardiac troponin measurements in place of standard troponin assays resulted in an increase in detection of MI and a reciprocal decrease in the diagnosis of unstable angina. You should understand that it is two forms without ST elevation. It is non-STEMI and unstable angina. It not have ST elevation too. And sometimes, according just to ACG changes, we come different unstable angina and myocardial infarction. And for this differential diagnosis, we usually need cardiac specific enzymes and especially troponins. Compared with non-STEMI patients, individuals with unstable angina do not experience myocardial necrosis, have a substantially lower risk of death, and appear to derive less benefit from intensified antiplatelet therapy as well as early invasive strategy. Okay, myocardial infarction. It can have a different definitions. Let's first of all tell a universal definition where MI defines like cardiomyocyte necrosis in a clinical setting consistent with acute myocardial ischemia. And we have our definition that detailized and more specific maybe for myocardial infarction. We formulate it in such way. Acute myocardial infarction is a disease or clinical syndrome accompanying other diseases, which is represented by acute coronarogenous aseptic inflammation of the part of heart wall, and clinically correlates with a stress reaction of body control systems and is determined by extent, localization, nature, and stage of structural transformations in the infarction zone, as well as circulation changes and their consequences. Epidemiology. Around the world, the acute coronary syndrome and coronary artery disease in general is the single most frequent cause of death in general in all morbidity in all population. Over 7 million people every year die from coronary artery disease, accounting for 12.8% of all deaths. Every 6 men and every 7th woman in Europe will die from myocardial infarction. Let's just imagine what the prevalence of this disease and acute coronary artery disease in general and acute coronary syndrome and MI. The incidence of hospital admissions for MI varies among countries. The most comprehensive STEMI registry is probably in Sweden, whereas incidence is 66 STEMI per 100,000 per year. And here you see a scheme of epidemiology of acute coronary syndrome in Spanish population, like an example for Europe. Here as you see number of acute coronary syndrome cases trend from 2005 to 20, maybe prognostically 49 by sex age group in the Spanish population. And you see that it was and now nearly the same, the highest level in men maybe till 74, and the lowest in women till 74. But it is raising of incidence of acute coronary syndrome in aged men and women, and till 50 years here we can prognose that incidence of a man acute coronary syndrome of aged men will be even higher than middle-aged men. And you see by the year quality of diagnosis. And here it shows that it depends strictly from diagnostic procedures. You see that STEMI and non-STEMI diagnostic till maybe year 1998 till the starting of 2000s year, there was nearly the same, but it is changed. It is better diagnosis and STEMI. Why? Because it is not you don't need don't have enough diagnostic tools, because ACG in most cases cannot show you non-STEMI. It looks like unstable angina or stable angina or no specific changes on ACG at all. And better diagnosing of non-STEMI started from year 2000, when it is troponin assay use, because what I told you in definition, for non-STEMI we need cardiac enzymes. Risk factors. Here you see a spectrum of coronary syndromes with the risk factors, and you see in the middle of it acute coronary syndromes. It is myocardial ischemia. Here is more important: acute myocardial ischemia, coronary thrombosis, MI, and it complications like remodeling, arrhythmia, loss of muscles, ventricular dilation, and others. It connected with acute coronary syndrome. And general risk factor the same with all coronary insufficiency. Yes, it is modifiable, non-modifiable: diet, smoking, obesity, lifestyle, drug using, hypertension, gender, age, and others. Please work more carefully at home with it. Etiology. The hallmark of an acute coronary syndrome is the sudden imbalance between myocardial oxygen consumption and demand, which is usually the result of coronary artery obstruction. Please read one more time this definition. It is sudden imbalance between myocardial oxygen consumption and demand. In general, if we give definition for coronary insufficiency, it is imbalance between oxygen supply and oxygen demand. But for chronic forms, it typical more gradual decreasing supply or increasing demand with formation some chronic forms of coronary artery disease. And here it is always sudden. And what sudden can happen in coronary artery? Of course, it is thrombosis. That's why acute coronary syndrome, it always thrombosis in place of atherosclerotic plaque. It is thrombosis of artery, and according to presence of block, level of this block, it can be unstable angina and STEMI and STEMI. The imbalance may also be caused by other excessive myocardial oxygen demand in the setting of stable flow limiting lesion. Acute coronary insufficiency due to vasospastic angina, coronary embolism, coronary arteritis. Non-coronary causes like hypotension, severe anemia, hypertension, tachycardia, hypertrophic cardiomyopathy, severe aortic stenosis. Non-ischemic myocardial injury like myocarditis, cardiac contusion, cardiotoxic drugs. Multifactorial causes like stress cardiomyopathy, pulmonary embolism, severe heart failure, and sepsis. Terms of reversible and irreversible ischemia. When in general we talk about ischemia, we mean in most cases a reversible process. Yes, it is not enough oxygen for tissue. Tissue suffer from this deficit, and it goes some processes of hypoxia in this cell and in cells in this tissue. But when it's starting of dying of some cells, like here cardiomyocyte, we name it not ischemia, we name it necrosis, and this process of course is irreversible. What can we talk about reversible and irreversible changes in case of acute coronary syndromes? For example, unstable angina. It develops until local coronary circulation disturbances cross the time of reversible ischemia. It is acute ischemia, it is acute block, but it's still in this place reversible changes. And if in this moment we do revascularization, it is normalizing of blood flow, normalizing of oxygen supply. All changes will return to normal. And what about MI? MI develop when the local coronary circulation disturbances cross the time threshold and make the ischemia irreversible. It is linked to necrosis. It is small zone or bigger zone. You see the lower pictures, yes, the zone of ischemia, and its starting formation the zone of necrosis. If it present zone of necrosis, it is always myocardial infarction, but around this zone of necrosis it always surrounded by ischemia tissue. It is zone, border zone of ischemia. Okay, key moments in mechanisms. Here please be attentive. Mechanism on an acute coronary syndrome was selected by evolution and consist at systemic and local levels. These mechanisms are aimed at providing most favorable of possible the acute coronary syndrome courses. Their disturbances build complications of the acute coronary syndrome. Systemic level, yes, systemic and local. What in systemic level in general in organism? The response of body systems to an acute coronary syndrome is realized through stress and manifests itself as a brain-mediated sympathetic activation and increased functional activity of hypothalamus, pituitary, and adrenal systems, with the change of functions of all target organs. Course and outcome of the acute coronary syndrome, all other conditions being equal. Inadequate organization of stress, or we name it eustress, it is normal stress. Yes, stress can be normal and it have to be normal. Yes, what happened, it happened. And next question, what organism to do it? If organism do normal things, some physiological, pathophysiological, but in normal borders response, we name it normal stress or eustress. If the response of organism is inadequate or no response at all, anything happened, or for example too high processes of response, it named not normal stress. Now we will discuss it. For STEMI, leukocyte reactions are important for further development of the process. These reactions are triggered by the ejection of leukocytes from the depot to the systemic blood flow. Since the depot mainly contains neutrophils, leukocytosis appears as the shift of cell count. Neutrophils are activated and migrate to the infarction zone by positive hemotaxis. Infarction zone products getting in the blood flow play the role of attractants for them. The activation of neutrophils appears as hyperenzyemia, higher contacts of eicosanoids, leukotrienes, in particular protein-carbohydrate complexes, and other biologically active agents. Stress is changed as the process develops and leukocytosis declines with the leukogram changes. Granulocyte counts decrease and their functional activity is suppressed, while the agranulocyte counts and their activity increase. The structural change of the leukogram is a result of controlling effects of infarction zone products, getting the blood flow neutrophil decay products from the infarction zone. are repellents for neutrophils and attractants for agranulocytes. As a result, an enzyme levels in blood falls, while the proteins and protein-carbohydrate complexes content grows. There are systemic manifestations of an inflammation process in the infarction zone. With the termination of an acute myocardial infarction phase, regulation problems disappear and not a trace remain the stress. And changes in local level. Local level, of course, here it is a heart. What in the locally happened in the heart after blocking and acute ischemia and necrosis? You see here a picture on the top panels, it shows infarction zone. At the bottom panels show the border peri-infarction zone. It's what I told you, that in the case of MI, in the middle it is zone of death, zone of infarction, and around it it is always border zone with acute ischemia. The components of pathologic processes are not only changes in the infarction zone and recovery of heart shape and size, but also adaptive changes of heart biomechanics. What happened in infarction in this core zone? All that happened is inflammation, special, aseptic, alterative, but still inflammation. The first one is ischemia, reversible myocardial changes, and non-ST elevation myocardial infarction. The transfer to irreversible changes, STEMI, marks the onset of necrosis, and with the transfer from ischemic changes in the infarction zone to the necrotic ones. The inflammation starts in accordance with its traditional scheme. The necrotized myocardium undergoes destruction, and decay products are removed through the peri-infarction zone. The necrotized myocardium is specifically destroyed by neutrophils getting by chemotaxis from the blood into the infarction zone and producing catepsins. Their migration rate is rather high, about 2-4 mm per hour, and even the largest possible infarction is infiltrated by neutrophils in 6 hours at the most. At the same time, fibroblasts precursors enter the infarction zone and the recovery process begins. It is impossible to separate necrotic and reparative processes, to look at them as the individual ones. They are synchronized and they interconnected not only at the level of the infarction zone itself, but also in the systemic blood level. The results of the natural inflammation course in the infarction zone for the formation of a full-fledged scar is a place of necrosis. Maturation of granulation tissue results in its consolidation, followed by a decrease in infarction zone sizes. Depending on conditions, they can decrease by 25% or more. I should remind those who want to strongly intervene in the infarction zone, yes, it is necrosis, it is bad, we have to do something with it. But we have to be very, very carefully. What phenomenon goes here? It goes inflammation, yes, necrosis, but its nature, hope you remember from pathophysiology, it is inflammation. It is inflammation, compensatory and adaptive responses. I remind you that it is protective reaction originated such a result of evolution. We name it evolution of myocardial infarction. And if we intervene in very, very strong way in this process and in this place, we will get not normal reparation, not normal evolution of myocardial infarction. That's why all our interventions have to be very, very careful. We may intervene in these processes, but carefully. It's what I told. All treatment you will learn in cardiology on 5th course. Now, just for understanding mechanisms. Okay, systemic mechanisms in peri-infarction zone and in the infarction zone are interconnected through the peri-infarction zone. First of all, through this microcirculatory band. Yes, in this core zone, which is dead, it is no circulation. That's why everything that goes in this zone, all that zone, the leukocytes, the chemicals, all that it get from the peri-infarction zone circulation, and it give its toxic agents, its product of necrosis through the peri-infarction zone too. Waste stress from the infarction zone are removed through it, and the products necessary for operative processes enter the same way. The larger the infarction peri-infarction zone interface, the better mutual effects of the infarction zone and systemic control. As larger peri-infarction zone, it have to be larger than infarction, that core zone, as better reparative processes. The peri-infarction zone can't be smaller than required for uncomplicated healing of the infarction. Okay, and changes in heart shape and size. In case of infarction, part of the myocardium, because disabled in its function, should be compensated. Hypertrophy of an intact myocardium develops. Healing of the infarction zone accompanied with the consolidation of scar leads to a decrease in its size. The heart shape is remodeled in such a way that its anatomic proportions are restored to favor in pumping functions. In the best case, the tracers of infarction are difficult to reveal, even after thorough investigations. Complications, frequency and immediate cause. Acute myocardial infarction is a complex of vulnerable process. The most optimistic estimations, its complications are observed somewhere in the quarter of cases, if it is diagnosed and treated correctly. The immediate cause of complications is inadequate stress or distress. Have little patience, and we would see how distress is relied as complications. Okay, standard mechanism. The cause of complication is distress. It what we told it can be, it have to be L stress, normal stress, and it can be something abnormal. This abnormal we name distress. And this distress can be three types. It can be hyperreactive, it can be hyporeactive, and intermittent. The mechanisms of complications, irrespective of distress type, is always the same, with desynchronization of necrotic and reparative processes. Desynchronization of necrosis and reparations, the processes go in the same time it goes necrosis and the same times it goes processes for reparation, leads to the loss of heart wall strength in the infarction zone with cardiac aneurysm and heart rupture outcomes. The result of hyperreactive distress is an intensive and rapid migration of polynuclears in the infarction zone with acceleration of necrosis and destruction of infarcted myocardium and lag behind of reparative processes. There is the desynchronization. Fast destruction of myocardium in the infarction zone has one more consequence. With high concentration gradients of all products form it in it along the boundary with peri-infarct zone with the electronic instability of heart, and as a result arrhythmia. Hyporeactive distress. In this case, everything develops very slowly. Systemic reactions are sluggish or absent at all. Thus, there are problems with the infiltration of polynuclears to the infarction zone, and the necrotic phase is slow, which leads to the delay of reparative processes and their slow development. There is the desynchronization again. Hyporeactive distress with a sluggish disease pattern determines a large size of aneurysm, and as a rule, heart rupture occurs in the thinnest area of aneurysm. Intermittent distress. Intermittent distress means superposition of the above mechanisms by the formula out of line pan into the fire, and everything becomes much more dangerous. Okay, classification. Classification, it can be several classification. First of them we give in definition. It is three forms: unstable angina and STEMI and STEMI. According to International Classification of Disease, we find it in chapter 9, diseases of circulatory system, and you see by the numbers of I-20 till I-25 it is ischemic heart diseases. I-20 it is unstable angina. I-21 it is ST elevation and non-ST elevation myocardial infarction. In I-23 it is certain carried complication following ST segment elevation and non-ST segment elevation, MI within 28-day period. Yes, we add it in case of different complication. And I-24 it is other acute ischemic heart diseases. Okay, types. We will discuss it one more time. It is ST elevation myocardial infarction caused by occlusive thrombus with ST elevation and cardiac enzyme elevation present. And STEMI, it is non-occlusive thrombus, non-ST elevation, no Q wave, but cardiac enzymes are present. They are always present in MI. And unstable non-occlusive thrombus with non-ST elevation, non-Q pathological way, and no cardiac enzyme elevation. How can we classify myocardial infarction? By the anatomic perspective, it can be transmural or necrosis go through the whole thickness of myocardial wall, and non-transmural. Non-transmural we can divide in subendocardial and subepicardial. By the localization, it can be anterior, lateral, posterior, septal, inferior, and MI of right ventricle. By the clinical periodization, it can be acutest. It goes clinically like unstable angina. It is for first 20, maximum 30 minutes. After it goes acute form, it is predominance of necrotic processes. After it goes subacute form, it is predominance of reparative processes. And post-infarction, after consolidation of post-infarction scar, it goes through during all life of the patient. By the causes, we can classify MI like non-complicated and complicated. And complicated, let's remember mechanism, it can be by the hyperreactive type and hyporeactive type. Okay, clinical investigation. First of all, of course, it is symptoms, clinical symptoms of patients and complaints. The cardinal symptom is chest pain, of course. It is intensive chest pain experienced as tightness around the chest and radiating to the left arm and the left angle of the jaw. This may be associated with diaphoresis, sweating, nausea and vomiting, as well as shortness of breath. In many cases, the sensation is atypical, with pain experienced in different ways or even being completely absent, which is more likely in female patients and those with diabetes. Some may report arrhythmia, anxiety, or a sense of impending doom, like anger, anemia, and feeling of being acutely ill. The description of the chest discomfort as a pressure has little utility in aiding the diagnosis as it is non-specific for acute coronary syndrome. Okay, here is shown common localization and patterns of chest pain. Yes, you see that it is first picture. It most usual mid-sternum pain with irradiation to the left shoulder and down both arms, neck and arms. It can be second picture substernal radiating to the neck and jaw and substernal radiating down to left arm. Very often case too. Next picture, it can be epigastric and epigastric radiating to neck, jaw and arms. And it is a typical localization, a typical irradiation too. That's why be very carefully with patient with epigastric pain. It's not included, for example, myocardial infarction in your differential diagnosis. And sometimes pain can be intrascapular. All these types are typical types. The characteristics of discomfort related to chest pain may be divided into 4 categories: location, character, duration, and relationship to exertion and other exacerbating or relieving factors. The discomfort caused by myocardial ischemia is usually located in the chest. It what we discussed near the sternum, may be felt anywhere from the epigastrium to the left jaw and teeth, between the shoulder blades, or in either arm or wrist and fingers. And distribution of acute coronary syndrome morphologically, depending on what artery is damaging by blockage, by obstruction. Yes, we remember that it is 3 main branches of coronary arteries. Yes, it is right coronary artery obstruction, left circumflex artery obstruction, and left anterior descending artery obstruction. This left anterior descending artery obstruction causes nearly 50% of all cases of MI. It is artery of sudden death. Yes, you know why this term, because very often we see manifestation of acute coronary syndrome from the death without any other symptoms before. And it usually causes anterior infarction. Less frequent, it is obstruction of right coronary artery. It's nearly 30% of all cases. It leads to posterior infarction and involves a posterior septum. And other nearly 20% of cases, it is obstruction of left circumflex artery. It leads to lateral infarction. What is in the history of patient? The history should include any current symptoms and complete inventory comorbid conditions. An inventory of cardiac risk factors and complete family history are essential components. The history should also include information about the character and location of discomfort, radiation of discomfort, associated symptoms, and precipitating, exacerbating, or alleviating factors. The importance of the family history should be not underestimated. A detailed assessment, particularly of first-degree relative for the presence of coronary artery disease and age of diagnosis, is imperative when evaluating a patient's risk factor profile. What in physical examination can you find in patient with acute coronary syndrome? The results of the physical examination of patients may be entirely normal. The presence of multiple risk factors or atherosclerosis symptoms increases in the likelihood that chest pain is related to myocardial ischemia. Evaluation should include measurements of blood pressure and ankle brachial index, cardiac and carotid arteries auscultation for Broods. Examination of the chest wall, neck, and shoulders are deformities, and tenderness may be helpful in diagnosing musculoskeletal chest discomfort. The physical examination may help identify comorbid conditions that impact therapeutic risk and decision making. Okay, let's compare myocardial infarction and stable angina. By the symptoms, in occurrence of pain For MI, it can occur anytime. For stable angina, it's more typical occurring due to physical or emotional stress. By modality of pain, in MI, it goes with damage to the heart and usually described as severe, steady, and crushing. For stable angina, it is with no damage to heart. By the outcome, MI may be fatal, stable angina usually not fatal. By relieving factors of pain, for MI, symptoms persist after 15 minutes and not relieved by the rest or nitroglycerin. For stable angina, usually symptoms relieved by the rest or nitroglycerin, and they are relieved during 10-15 minutes. By the duration, for MI, it usually lasts more than 15 minutes. For stable angina, less than 15 minutes. Usually, in most cases, discomfort is transient, lasting 3-5 minutes. Patients stop, and in 3-4-5 minutes, pain stops too. Okay, non-complicated MI. In clinical investigation, one of the first places in additional testing takes ECG, electrocardiogram. And in this picture, you can see ECG of non-complicated myocardial infarction in the different periods of time. I told you that it can be acutest, it can be acute myocardial infarction, subacute myocardial infarction, and post-MI patient. And these different stages we can see here, and according to ECG changes in a damaged region, we can suspect what stage of MI in this patient. First picture. It is normal ECG complex. All waves are present. They are nearly normal size. Usually Q wave, it is very, very small. It is high positive R wave. It is normal size S wave. After it, ST segment between QRS complex and T wave. It is a piece of ECG that placed like a line on isoline, and after it go normal size and form T wave. Second picture. What goes wrong? It goes wrong something with QRS complex, ST segment, and T wave. What is affected by myocardial infarction? It is ventricles. What can we see here? First of all, first and the most specific sign, it is ST elevation. You see that the place between QRS complex and T wave that we name ST segment rise upper the isoline. Moreover, at the same time, it starting enlargement of Q wave. It can be wider, it can be deeper, like here a little bit. But it's still normal size R wave. ST segment, it is elevated, it is upper than isoline. After it goes to the isoline, ST segment goes in T wave and in this form returns to isoline. It is first stages of acute form. Third picture, it is acute form 2. It is acute form 2. It is the maximal progressing of necrosis and progressing of myocardial infarction. What can happen there? Like on this ECG, Q wave become wider and deeper. You see a big Q wave. Such a big Q wave we name pathological Q. It will be Q positive myocardial infarction. In this picture, after it, you see positive R wave. Maybe it is a little bit lower, it is a little bit slower, and in a lot of patients it can be absent at all. You cannot see this peak of R. It in the same way goes in ST elevation. Here it is present but a little bit low, and after it, it goes ST segment elevation. It is become even higher than in previous picture. With progression it goes higher, 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 and stopping the same in the same place. And you see that it returns to isoline and gives negative T wave. We name this process T inversion. T wave becomes negative and it goes after the ST segment elevation. It is a typical picture, maximal picture of progressing of myocardial infarction. The next fourth picture, it started subacute or a starting of reparative processes that are prevalent in this stage than necrotic processes. What is here? Q wave. Q wave not changes after the acute form, it not change at all, and if it present pathological deep and big Q, if MI is Q positive, this patient during all his life, even after the recovery, will have this deep pathological Q. That's why Q will be always from this moment pathological. Q wave is deep and big. After it go some R wave, yes, nearly the same with the third picture like in acute stage, but ST elevation become low. ST elevation become low. For you, it is a first sign that reparative processes in this moment go more intensive than necrotic processes. And for you, it is starting of going from acute phase to subacute to reparative phase. But in this moment, it is very affected repolarization and relaxation of ventricle. That's why inversion of T, negative T, become even bigger. What the next phase? It is nearly in several months. Fifth, we can see a picture like on fifth ACG. It will be pathological deep big Q. R wave, it is nearly normal, it can be little bit lower or it can be significantly lower. Yes, if it is changed during acute phase, it is state changed. But here in this picture we see that R present, but it is a little bit lower than before MI. But ST segment return to the isoline. It means that it is goes normal reparation, normal scarring of this place of myocardial infarction, but it's still subacute phase because it is affected repolarization processes, and you see that T wave is negative. It is still inversion of T. And we can say that it is post-MI patient, that it is finished reparation, just in case when you see sixth picture. When it is QRS complex, it can be changed from the first picture. Yes, it is deep Q wave. R wave can be a little bit lower. Yes, it can be a little bit changes because of presence of scar in myocardium, but it's still present QRS complex, nearly normal form that reflected constriction of ventricles. ST segment will be absolutely normal. It returns to normal and says you that it is normal reparation is finished, has finished, and T wave is positive. Positive, nearly normal form. It says you that repolarization is normal too. It is one more sign of normal reparation. It is a picture of post-MI patient. And these changes you will see on ACG, not in all leads. You remember that standard ACG include 12 leads. 1, 2, 3, AVR, AVL, AVF additional, and chest lead from V1 to V6. And according where you see these changes, like in previous picture, you can suspect what localization of myocardial infarction. For example, if you see these changes with affection of first lead, AVL, V5, V6, it says you about lateral MI. If it is affected second, third, and AVF, it says you about inferior myocardial infarction. And if it affected V3, V4, it says you, sometimes in this case it can be first lead too. It is a sign of anterior myocardial infarction. Complications. Complications may occur immediately following the heart attack and may need to develop. Acute complications may include heart failure, aneurysms of the left ventricle myocardium, ventricular septal rupture or free wall rupture, mitral regurgitation, in particular if the infarction causes desynchronization of the papillary muscle, Dressler syndrome, and abdominal heart rhythms such as ventricular fibrillation, ventricular tachycardia, atrial fibrillation, and heart block. Longer-term complications include heart failure, atrial fibrillation, and an increased risk of a second MI. And outcomes by the time of most often complication by the time after myocardial infarction. Yes, in a moment of MI, what can cause? It can be sudden death or some acute arrhythmia formations. Its most typical complication during first day of myocardial infarction. During first week, it is, we name it early complication, 90% it is arrhythmia. More than half cases, it can be chronic heart failure, it can be shock and heart rupture. During first year, we name it late complication. Here on the first place it is heart failure. Nearly 70% of patients suffer from heart failure. In 20% of patients it stays arrhythmia, it can be aneurysm and thromboemboli. And in very long prognosis, nearly 10 years, it can be chronic left heart weakness with formation of chronic heart failure and recurrent infarcts and arrhythmias. Diagnosis. Blood test. Here on the first place it is cardiac biomarkers. Moreover, we check white blood cells, cholesterol, and C-reactive proteins levels. We do electrocardiogram. For visualization, we can do ultrasonography in B mode, Doppler, and intravascular ultrasound. For today, the gold standard of diagnosing it is vascular catheterization and angiogram. And in some difficult cases, it can be other imaging tests. And you see the initial assessment of patient with suspected acute coronary syndrome. We can't make a diagnosis just from symptoms or just from ECG or just from cardiac biomarkers. It is always multifactorial diagnosis. You have to do at least these three things. Take symptoms, do ECG, and check cardiac biomarkers. And according to it, if it present chest pain or other infarction symptoms, if it present typical ECG symptoms, and if it positive on all biomarkers, mostly troponins, and according to it, we can make a diagnosis. Is it not cardiac problem at all, or unstable angina, or other cardiac problems, or for example stable angina, or non-STEMI, or STEMI. Criteria of diagnosis of MI. A combination of criteria is required to meet the diagnosis of MI, namely the detection of an increase and decrease of cardiac biomarker, preferably high sensitivity cardiac troponins with at least one value above the 29th percentile of the upper reference lipid, and at least one of the following. Symptoms of ischemia, new or presumed new significant ST wave changes or left bundle branch block on 12-lead ECG. You should remember that left bundle branch block acute, it is equivalent of ST elevation. Development of pathological Q waves on ECG. Imaging evidence of new or presumed new loss of variable myocardium, original wall motion abnormality, intracoronary thrombus detected on angiography or autopsy. Cardiac biomarkers. Okay, I told you several times that the most specific cardio biomarkers are troponins. And they are really the most useful, most specific, and in most cases we use troponins, T or I. But troponins have some problem. This problem is they are too late. Usually they become positive after 12 or even 24 hours after starting of myocardial infarction. And when you will learn the treatment of MI, it goes from the hours, even from minutes. We have just minutes or at least hours to do something. That's why in most patients with myocardial infarction it is too late. And we have to do something with these acute and acutest patients, first minutes and after hours after MI, when troponins are not positive. What can we do? For these patients, during first day of myocardial infarction, the most useful enzyme, it is CKMB. It is a MB fraction of creatine kinase. It is much more earlier than troponin T and I. It is a little bit less specific, but in complex with other symptoms, with the ICG changes, they are very informable. And we have one more usable enzyme, it is myoglobin. CKMB starting to increase after 30 minutes and sometimes after 1 hour. And some patients come to the hospital earlier. Yes, and this patient in first minutes, in this acutest and first minutes of acute stage, sometimes we need to confirm MI to start to do something. And troponins are still negative, CKMB is still negative, and for this case we have myoglobin. It is even less specific than CKMB and of course less specific than troponins, but it is a very informative in a patient with chest pain during first minutes. And here you see LT and LDH and other enzyme, but they are not specific at all. And like additional sign, we should know about them, but we not use it for confirming diagnosis myocardial infarction. Indications of measurements of troponins. Cardiac troponin I and T have displaced myoglobin and creatine kinase MB as preferred markers of myocardial injury. Serum levels increase within 3-12 hours from the onset of chest pain, peak at 24-48 hours, and return to baseline over 14 days. Troponin levels may not be detectable for 6 hours after the onset of myocardial cell injury. The most sensitive early marker for myocardial infarction is myoglobin. Troponin levels should be measured at presentation and again 10-12 hours after the onset of symptoms. When there is uncertainty regarding the time of symptom onset, troponin should be measured at 12 hours after their presentation. The risk of death from an acute coronary syndrome is directly related to troponin level, and patients with no detectable troponins have a good short-term prognosis. Elevated troponin levels can occur in patients without an acute coronary syndrome and are associated with adverse outcome in many other clinical situations, including congestive heart failure, sepsis, acute pulmonary embolism, and chronic kidney disease. Other cardiac causes include myocarditis and aortic dissection. ECG. Here you see an example of ECG of real patient with ST at T changes in lead 2, 3 AVF. They are solid red cycles. It is a suspicion of ischemia of the inferior myocardial wall. Similar change is outlined in the lead V6. Here you see inferior STEMI 2 in acutest phase. You see that it is no other changes, just ST elevation, no pathological Q, no inversion of T. It is acutest phase, and we see changes in 2, 3 AVF. What is typical for inferior myocardial infarction? Here an inferior STEMI with right bundle branch block on ACG. The reciprocal depression, you see the in lead 1 and AVL. You see the elevation, the acute MI, it is inferior MI2. You see elevation and second, third, and AVF. And you see some depression in lead 1 and AVL. It what we named reciprocal. It's not due to natural ischemia in this place. It is a compensatory, like half myocardium suffer from those myocardial infarction, and usually they, like a mirror, show changes in zone of recursion if they are elevation in opposite side anterior depression. Okay, and one more time for you, table with diagnosis and criteria of differentiation, non-complicated and complicated myocardial infarction, and according there is hyperreactive and hyporeactive distress. Yes, blood leukocytes. In a non-complicated MI, it will be from 7 till 11 with rapid decrease. For complicated, it more than 11 with slow decrease, and complicated hyporeactive less than 7 with slow decrease. Shift of leukocytes goes in non-complicated from 3 till 6.5 with a rapid decrease. In complicated hyperreactive, more than 6.5. And for complicated hyporeactive, less than 3 with a slow decrease. Time of maximum activity of enzymes in hours in non-complicated with areactive stress MI. It is from 16 to 22 hours with rapid decrease. For hyperreactive, more than 60. For hyporeactive, less than 60. And for hyporeactive, more than 22 hours with slow decrease. Initial period of protein carbohydrate complex growth in days. Non-complicated 1-2 days, and for complicated, as for hyperreactive distress, it is more than 2 days. Period of reaching maximum protein carbohydrate complexes concentration. 4-5 days for non-complicated, and more than 2 days for both types of more than 5 days, for both types of complicated myocardial infarction. Interval between myxedema of enzymes and protein carbohydrate complexes. For non-complicated with areactive stress, more than 4. And for complicated, it is less than 4, and for complicated, for both type, more than 6. And return of ST segment on ACG to the isoline will be in as for non-complicated, as for hyperreactive complicated, as for hyporeactive complicated, it will be more than 36 hours. Okay, my dear friends, for today that's all. It's all information that I have for you. I'm glad to see you, and I'm glad everyone who listening my lectures. I will continue my lectures according to internet connection, but I try to do it synchronously with your schedule, with your thematic plans online, and I leave all recordings of lecture on my YouTube channel. Who are not able synchronously listen lecture, all recordings are present in my channel on YouTube. But I have a not stable, due to war, not stable internet connection. That's why not all recordings completely safe on YouTube. That's why if you have possibility, please listen it online according to your schedule. And as usual, like for all my groups, I ask our MM groups of third course in Propaedeutics leave your name and number of group in comments under the video. For me, I usually see who listening my lecture, which group was more active and which groups less active. And if you have comments, if you have some feedback, if you have some maybe complaints, maybe questions, you always can contact me on Facebook, for me individually, for each teacher of our department, for your practical teachers, and you can write in our Facebook group. We always glad for feedback from you. And you can write your questions under the video in comments on YouTube. That's it all for today. See you in 2 weeks. It will be very interesting.